Hi, everyone. Hopefully everyone's back. We're trying our best to keep on schedule. I know it's not easy with a webinar for half a day. So without further ado, we're going to have a wonderful presentation by Dr. Brian Wong, and I'll let Dr. Wang introduce Dr. Brian Wong.
Great, thank you, Raj. So I actually saw Brian the first time when he was giving a plenary talk at ICRE back in 2018, and you were speaking to over, I think, 1,000 participants at that time on medical education. And little did I know that, in fact, you were actually housed at Sunnybrook as well, the same hospital that I work at. And it's been a pleasure getting to know you a little bit better, attending the CEQUIPS program and getting guidance from you there around QI education. So let me just introduce Brian. Brian is a staff physician at Sunnybrook in the Division of General Internal Medicine. He's also associate professor in the Department of Medicine at the University of Toronto. He holds several university-wide leadership positions related to quality improvement and medical education, and he's served as the Director of Continuing Education and Quality Improvement since 2011. We're also very excited because he was just recently named the director for the Center for Quality Improvement and Patient Safety at the University of Toronto. And I know that you also recently helped to launch the fellowship program, so that's very exciting indeed. Nationally, he is a clinician educator with the Royal College of Physicians and Surgeons of Canada and the Medical Education Lead for Choosing Wisely Canada. And his scholarly activities lie at the intersection between medical education, quality improvement, and patient safety. And he's also been extensively involved in developing curriculum to teach patient safety, quality, and resource stewardship to health professionals. He's chaired the CanMed's 2015 Patient Safety and QI Expert Working Group and authored a report that informed the eventual integration of patient safety and QI competencies into the CanMed's 2015 Physician Competency Framework. So thank you so much for joining us this morning, and we look forward to your talk.
Thanks so much, Karen, for that very generous introduction. And I actually have a pretty sort of fond history with the CPPD group, in that early days when there was a decision to really think about how to better integrate and align practice development and personal or professional development. I was able to be involved in sort of some of the discussions around how to think that through, given that in the Department of Medicine, I hold a role that really tries to align and integrate CPD and QI. I just want to make sure, Karen, is the audio okay right now on the presentation?
Yes, we can hear you.
Okay, perfect. So the objectives here, by the end of this presentation, I hope that you'll be able to describe ways that data within the health system can be utilized to identify urgent health system priorities, how you can pursue interprofessional and multidisciplinary team-based approaches to CPPD, and really to recognize the importance of aligning CPD and QI to organizational priorities. And, I had mentioned to Karen that, in fact, the main areas of focus I would try to tie in some of the concepts from earlier today. And I had to step away for an hour, unfortunately, during the middle of the morning, but I was able to hear all of Ivan's presentation in the first part of the plenary around measurement-based care. And so hopefully some of these themes around CPPD being data-driven, team-based, and organizationally aligned will resonate. It's obviously also a very unusual time for all of us, and for me, particularly in my career, I sort of started to explore an area that I was very unfamiliar with, and I was sort of struck by an article that I read in the newspaper in late February around a long-term care outbreak in Washington State, just outside of Seattle. And at the time, I was, just started in my role as the director for the Center for Quality Improvement and Patient Safety. I had been a card-carrying hospitalist and general internist for, almost 15 years, and really had very little experience working in long-term care. And yet I'm going to be making my work in the last 6 months with a whole bunch of other people in long-term care, the focus of how I'll try to sort of talk through the importance of being data-driven, team-based, and organizationally aligned. So, but here's a major disclaimer. I actually don't work clinically in long-term care. In fact, I never have. I'm a primary care, I'm primarily a hospitalist. Much of what I know about long-term care basically dates back to early March. Although I have some lived experience with my grandmother who once lived in long-term care. But I had assumed the role as the Center for Quality Improvement and Patient Safety Director in 2020. And as Karen mentioned, I really have spent most of my sort of the first 10 years of my career on quality improvement education. And I think that it's been impactful insofar as we've built capacity for quality improvement work to occur in organizations. But I really was hoping to take CQIPS to the next level and think about how could we actually more directly impact the health system. And so, unfortunately, here we are, and we are looking at the current pandemic wave. And I know that it's an uncertain time, much like it was in the beginning of March. But I had taken over as the director for the Center for Quality Improvement and Patient Safety, as I mentioned, and we were at a point in early March where, as a team, we had decided to announce to our members that we had a singular focus. And that singular focus was to do whatever we could within our sphere of influence to try to contribute to the response to the pandemic's first wave. And I actually will say, I will remember that Karen was one of the first people that emailed me back and said, how can I help? And actually many of our members did. And we actually didn't really know what that urgent need would be within the health system. But I'm going to tie this back very shortly to long-term care. So one of the ways to figure out what the health system's needs are to be data-driven. And so here's the data around where our health system struggles. This actually predates the pandemic. So this was an article in January of 2020. And it's hard to remember really what it was like in January 2020, but those of you who work in acute care settings will know that there was all this discussion around how we were going to eliminate hallway medicine, right? And that our acute care hospitals were over capacity. And here are the top 10 hospitals in Ontario, and the number of days they were over 100% capacity. Like the majority of these hospitals, these top 10 hospitals, they had more days than not where their occupancy was over 100%. So, the data, if you were to look in a very concrete way, would tell us that one of the major health system needs we have is around building resilience in our health system to be able to respond to these unexpected shocks like the pandemic, like we're seeing right now, in fact. The data was also starting to come out around just how vulnerable the long-term care sector was. And as much as I was a hospital-based physician at the time, and still am, it was hard to ignore the data that was coming out of this one example in King County in Washington State, where there was a confirmed outbreak in a long-term care home affecting 101 residents and 50 staff and 16 visitors. Now, you have to remember that was probably one of the first sort of public reports of a major outbreak in a long-term care center. And it actually, if you go back to this article in the New England Journal, it actually very, very clearly describes what unfortunately we have seen in many circumstances, unfortunately, around the world and in particular in Ontario. Whereas, in Canada, 5 out of 6 deaths due to COVID occurred in long-term care homes. And so these data were very, very striking. They told us that if the community-based spread affected long-term care, that we would see a great deal of morbidity and mortality. I'll also remind you that we were also seeing data coming out of other parts of the world that really gave us pause in terms of whether or not we were actually going to be ready for a potential surge as part of the first wave. You'll remember Northern Italy, you'll remember New York State, and that was really the context in which we were trying to prepare for the first wave of the pandemic. And in fact, you might have seen this was in the end of March. There was a lot of mathematical modeling and epidemiologists who basically were trying to predict what would happen based on the different types of scenarios and what would happen based on how we as a society would respond to the pandemic. Now, what you'll know probably is, in fact, we never even reached the current available capacity line because the public health measures that we put in place in the spring worked very effectively. And for sure, we saved lives. But at that time, the data was telling us that there was a real concern that we would not have enough acute care capacity potentially to provide for people who had a COVID-19 infection. So, you know, when we talk about how do we identify health system priorities, it is important to be able to identify those needs based on the data that's available. And that was the data that we were looking at as a society. And so at that time, the data was pointing towards an urgent health system priority around enhancing our ability to provide better care to residents in their own environment. But it was at least partially motivated by the idea that we could not afford to, you know, and I'll use these words carefully, but these are the words at the time, which was there was a concern around overwhelming the acute care system. You have to remember at the time, there was concern around availability of PPE, there was a concern around the availability of ventilators, there was concern around the availability of medications to provide for people. But we knew that in order to do this, we needed to be able to bring some of the care that is only available currently in the acute care system into the long-term care environment, okay? Now, remember that, again, prior to the pandemic, the data would suggest that transferring long-term care residents to acute care unnecessarily is undesirable. Okay, there's clear evidence that individuals who get transferred when it's potentially avoidable, they suffer worsening delirium, they are at risk of hospital-acquired infections, there's discontinuity of care with respect to their care planning. And in particular during the COVID pandemic, there was concern, in fact, that we would expose residents to the risks of infection, either with traditional hospital-acquired infections, and in particular COVID-19. And you'll also probably know that many long-term care homes had policies where once someone came back from the acute care sector, they would be immediately put into a 14-day quarantine, which many residents and families were trying to avoid for obvious reasons. So, you know, when we were using the data to identify the health system need, it's important to then think, okay, how does the data help us to figure out how to fix this problem? And one of the key principles in quality improvement is you have to understand the problem before you put a solution in place. And again, data can be very helpful in this regard. So I'm going to actually go through 3 or 4 different data sources to give you a sense of how we were able to have a look at the problem through different lenses. So the first thing we did was actually just look at the published literature. And so the published literature told us that actually up to 50% of transfers to acute care don't even require an admission to hospital. And in fact, there's a group in Toronto that we partnered with that is part of our group called Gemini. Gemini is a data set of right at the time 7 hospitals, but they're growing to 30 hospitals across Ontario. These are hospital admissions where they have really, really detailed data around the diagnoses, the treatments, the outcomes, and we were able to analyze the subset of patients admitted to hospital who came from long-term care to really try to understand what are the actual care needs that we might need to try to provide in the long-term care setting. So it turns out that 1 out of every 8 admissions to general medicine in Toronto come from the long-term care environment. Typically, people stay 7 days, but a quarter of them actually only stay 2 to 3 days. And so again, if you kind of think about the ones that might potentially be avoidable, the shorter stay admissions, in fact, might be more avoidable than the longer stay ones, for example. What was quite telling, though, was that 1 in 10 or 1 in 11 transfers actually resulted in the person dying in hospital. And again, there's a huge push, and I'm not going to talk as much about it today, around the importance of advanced care planning and palliative care and long-term care. But certainly this is quite telling that this is a patient population with a great deal of comorbidity. But what that data set, that Gemini data set, told us was, in fact, what are the common diagnoses? And these are not surprising for any of you that have worked in a hospital environment. These are the types of conditions that would be very typical, I think, of a general medicine unit, but obviously typical of a long-term care population as well. And so it helped us to start to think about, okay, well, what is it that we need to be able to treat a urinary tract infection in a long-term care setting, or heart failure, or electrolyte disorders? Well, it turns out we were actually able to identify, based on that data set, the types of treatments and procedures and tests that were ordered in these patients. So we identified the types of labs they needed, the types of medications they received, the types of diagnostic imaging that were performed. And it helped us to understand, okay, so what do the patients receive in hospital, and what do we need to provide in the long-term care setting? We then had the opportunity to just have a bunch of short telephone calls with medical directors, primary care providers, directors of care in 4 or 5 homes. And I will say that this is not qualitative research, but we took a qualitative mindset towards these conversations. So we tried to talk to people in homes of different sizes, with different level of resourcing, with different levels of engagement. And we tried to talk to a diverse set of people within the long-term care home. And really what we were trying to do is explore their experiences and to characterize the barriers to providing optimal care. And what we found was, and you'll probably have heard about this or read about this, that there are a number of barriers. And the reality is that some of the barriers that they identified were going to be very difficult for our intervention to address. Like, we didn't really have a lot of influence over staffing ratios. We didn't have a lot of influence over the culture of calling for help, okay? But we did have potentially the opportunity to think about ways to bring more services into the home and more support. We also started to recognize a couple other barriers that are not listed here, but the concerns around safety and the availability of PPE, and also the visitor restrictions, which obviously have gotten a lot of attention and continue to be a challenge. So what I've tried to outline for you is this an example of how oftentimes one needs to really draw upon a variety of different data sources. And so we had data from, like I said, a large registry. We actually also had data from the Toronto EMS. So I didn't show this, but we actually had data from Toronto EMS that told us what were the reasons for transfer. And I'm going to show you some of that data in a second. We looked at previously published data. And then all those interviews, they helped us to figure out, they weren't even interviews, they were just conversations. They helped us to understand the context so that we could design our intervention. So what did the intervention look like? So we very rapidly pulled together a team of quality improvement experts, data analytic experts, virtual care experts, and worked very close partnership with our long-term care colleagues. So we had assembled this new team to try to provide additional virtual support to long-term care homes in the Toronto region. The theory of change was that we would support primary care providers that work in these homes to provide high quality care, and that we would try to leverage and coordinate existing resources and add some new ones. And so the way it works is if you're a long-term care provider in one of these homes, you can call a phone number. We actually were able to register 1-855-LTC plus as our phone number, and we have a website. And if you called right now, there's a simple sort of decision tree where if you hit 1, you immediately get put in touch with the general internist who will call you back within 30 minutes, and you get an on-the-spot physician-to-physician virtual consult. If you press 2, you speak to a nurse navigator, and the nurse navigator would extend, sort of help to coordinate access to a variety of different community-based services, including behavioral supports provided through Baycrest, Jerry MedRisk, but also palliative care, wound care. And then we also worked with community-based service providers to try to provide enhanced access to stat blood work and diagnostic imaging, and produced a webinar series for primary care providers. And so that is my first hint at how CPD and QI can be combined, because we really utilized CPD as a way to entice people to learn more about our program. So when we had a problem with uptake, what we decided to do was start to launch a webinar series. This webinar series would include topics like how to manage COVID in a long-term care setting, how to engage in advanced care discussions, topics that were brought forward by our primary care provider colleagues as topics that were perceived needs. And then what we would do is we would combine those perceived needs with discussions around their unperceived needs, like if you have trouble with respect to managing these residents, how can we help? And so we actually use the education as a way to enhance the uptake and adoption of our program. So there's one example of how CPD and quality improvement were aligned. So here's an example. So the whole program is organized through an acute care hub and long-term care spoke model. And we very rapidly now have expanded to support 52 homes in Toronto. And we're very data driven. So this is data, this is the data dashboard, and the y-axis is a number of transfers per day. So we get this data actually from EMS every single day. So the Toronto Paramedic Services, they actually, I didn't know this when we started, so this was a kind of a neat thing about data, is that there are data sources everywhere, and sometimes you just don't know about them. So the EMS captures in a database every transfer to hospital via 911 and the address where the person was picked up and the address of the hospital where they were dropped off. And so based on that, we were able to identify the long-term care homes that we were registered, and then we could track on a daily basis transfers. And as you can see, there was a significant dip in the transfer volumes around the first wave of the pandemic, and there was a significant reluctance to transfer. But you'll notice actually, in fact, that we've kind of come back to our prior baseline, and I'll be interested to see now as we're deep in the middle of the second wave, what will happen. We also have data though on the number of consults that we provide, and this is what we call a fidelity measure. These are the number of consults we provide through general medicine, and it tells us the degree to which our intervention is being taken up. And as you can see, I'm being very honest with you to say that we have a long way to go, right? You can see that despite the work that we're doing, there are many days where we don't get any consults, yet there are transfers. And so we have a big job to do still in terms of figuring out how to increase the adoption of our intervention, which we believe works. And why do we believe it works? Well, we have some data on the early program impact that we've built into the day-to-day operation of the program. So after every single general medicine consult, we have a survey, it's really short, that the general internist and the primary care providers fill out. And we've done 170 consults, and 52% of them were deemed to have contributed to avoiding a transfer. And these are the types of cases that we look after. Someone who's delirious, diagnosed with hypercalcemia with our stat labs, and then treated with subcutaneous fluids. Someone who had left leg swelling who had an urgent mobile diagnostic imaging ultrasound, and then in consultation with general medicine, decision around treatment with an anticoagulant, or a resident with wandering behaviors with an acute COVID infection managed with support by the behavioral outreach team, coordinated by the nurse navigator. And so we now have some data from the subset of homes that we defined as early adopters. And what we said was these were the homes that requested 10 or more consults in their first 3 months involved in our program. We thought those were the homes that really were had really taken up the intervention. And this is a control chart, so many of you, I'm sure, will know how to interpret these. But what you'll see is similar to the pattern in all the homes, there was a drop, a pretty significant drop in the transfer rate. And then what you'll notice is there's been an increase, but the increase did not go back up to the prior baseline. And in fact, there's been a 25% reduction in the acute care transfers in the homes that were early adopters of our intervention. And we're really trying to understand that better and have applied for a grant to see if we can better understand this phenomenon. But the reality is that we can't ignore the data, right? And what the data tells us, in fact, is that actually our intervention is unlikely to address all the problems that we've identified, because actually, if you look at the data from EMS, and so these are on the y-axis, the number of transfers, and this is what's called a Pareto diagram. And the bars tell us the different categories of the reasons for transfer. And the blue line is the cumulative frequency. And we often use Pareto diagrams in quality improvement, as you know, to prioritize our efforts towards the problems that are the most prevalent. So you'll notice that respiratory problems was the most common category, contributing 18% of the transfers. But in fact, actually trauma and falls and injuries made up another approximately 16% of the transfers. So it's like 1 in 6 transfers are due to trauma. And in fact, if you look back on the published data, many of the people that got transferred and went back to the long-term care home without an admission were often for injuries where they needed to come over to get an X-ray or sometimes a CT scan. So how are we going to address that issue? So I'm just going to turn to the moderators, and ask, maybe if I haven't been keeping an eye on the chat at all. So I don't know if there have been any comments in the chat, or if we wanted to just pause for a few minutes and see if there are any questions around the role of data before we move on to team-based approaches.
Thanks, Brian. Yeah, if anyone has any questions so far about the talk, or as it is a very fascinating and relevant topic in light of what's happening. And I think this whole issue was front and center not too long ago, the first wave, if I remember, about finding ways of how we're going to manage outbreaks in long-term care centers. And I think I was going to ask you a question on the first part. Did you, obviously this is a very good approach of how to manage things, and you have the scientific, the data-driven approach where you know that maybe keeping them in the long-term care home with consultation and support is the best way to go. Did you get some resistance or some backlash from family members of patients wanting the exact opposite, where they were worried about COVID or something, that the care would be better at a hospital setting versus obviously that your data and research shows that it is better in long. Tell me a little bit about that and how you manage that.
Yeah, so the intervention was designed in a way where it was really focused on the primary care providers. So anytime there's a discussion around whether someone needs to be transferred or there may be a role for transfer, there's typically a conversation with the resident or their family member or caregiver. So some of the conversations and some of the advice that was provided was around advanced care planning. Sometimes what we would do as a consultant would be able to, would say, one of the questions families would ask is, well, what treatment would be different in acute care that we can't get in long-term care, right? And so what would be helpful sometimes is for us to say, okay, based on the diagnosis that we think is at hand, these are the things that we would do. And this is the added benefit of being in hospital. And you know the downsides, because most families recognize that having someone go to the hospital, and remember, there were no visitors allowed during some of these times, right? So you have an elderly patient with cognitive impairment admitted to hospital in an unfamiliar environment. There was a lot of reluctance to acute care transfers. Now, I think it's different now looking back, right? I think that there's understandably in many pieces, there's quite a bit of anger around how the situation in long-term care was handled. I think that there's a lot of mistrust in some places. So I think that our job is to make sure that we adapt our intervention to the changing context. Again, it's data that's coming in from, you need to have the ability to monitor for data in all different levels, right? And I would say at the macro level in our society, the data is telling us that, you know what, we can't frame this intervention around ED avoidance, avoiding acute care. It has to be about, we want to provide the best care to long-term care residents in keeping with their goals, right? That's what we want to do. So
I was going to ask you another part. You had mentioned that you had a unique way of gathering the data through the EMS people. And first, how did you go about doing that? And how did you get the buy-in from the EMS and other folks? Because, I mean, you would probably have to deal with a lot of bureaucratic tape and confidentiality things. Tell me a little bit about that piece.
Yeah, so I mean, yes, for sure there are issues, and luckily we have a data infrastructure to be able to house data securely, and we have a data sharing agreement that's being that has to be in place. But it was through conversations. So one of the things that we did, one of the early conversations we had was with EMS. Because I wanted to understand what their experience was when they would show up for a 911 call. What was the environment like? What was the care? Who was on the ground? That kind of stuff. And in those conversations, we just kind of threw it out there and said, because we knew EMS collected data. And so we just kind of threw it out there and said, look, like, we're trying to figure out a way to track a metric around the intervention. And they could see that we were going to try to use this data to try to avoid unnecessary transfers to hospital, which they cared deeply about. Because, from the EMS point of view, it's very disheartening to show up, see someone who could potentially be looked after in the home, but then bring them to the hospital and then sit in the emergency bay for hours waiting to offload, and seeing someone who's elderly deteriorate or get confused, and it's not a rewarding type of thing to have to do. So, I think what we did was we tried to find common ground around where we were both interested. And I think the third part of my talk is going to be around alignment. And I think we had an aligned interest around working to help support long-term care.
One more question, and then I'll let you continue for the next phase, is the aspect about the administrators. Anytime you bring in any type of quality improvement project, there may be always a sense of nervousness. What's going to happen? Is it somehow going to reflect badly on our care home or our processes, our administration? How did you, I mean, this goes with any quality improvement, but this in particular, the sensitive nature and what was happening at that time, how did you talk? Is there a certain approach that you had talking with the administrators to get the buy-in and kind of move forward? Any thoughts on that?
Yeah, I think what we did, we tried to do was, so first of all, we were not coming from the outside in. So we always worked with the individuals at the homes. So at the core of our team are a whole bunch of medical directors, primary care providers, nursing staff in the long-term care setting. So everything that we design, every intervention that we put in place, they're designed with long-term care providers and leaders at from the very beginning. And so it's not acute care saying this is how we're going to fix long-term care. it's not acute care parachuting in and then leaving. We're sort of like, we're trying to create a collaborative partnership across the sectors. We try to approach the work with humility, recognizing that we don't know the sector, we don't work there, you know, but we want to bring whatever we can to help support. And then the last thing we do is we're not trying to replace the people that are already there doing the work. We're there to try to enhance the services available. I see a question in the chat from Joe just around, this is how do we address the need to quickly increase data literacy? So I think I don't know what the right answer is. I do think that there is an opportunity in QI. Again, this is another example of how we can bridge QI and CPD is to actually take the time when sharing data. I didn't do it all that well today, to be honest, but you can really take the time to present data in a way that's understandable. I think that breaking it down for people, I think not overwhelming them with a lot of information, keeping it relatively simple in terms of how you display the data can be very helpful. I think that if it's a group that you're going to come back to over and over again, you might want to invest then in actually spending a little bit of time up front, helping them understand how to interpret these different charts. So I do think that there's a real important element around making sure that people understand how to interpret the data, but we have a job in presenting it and displaying it in a way that's easy to understand as well. So I think that would be my comment. So maybe I'll just move on now to think about, okay, what are some team-based approaches? And this is I think this is the part of the initiative that I have to say I'm probably the most proud of, because as I showed you in the chart, we have not had uptake of the intervention in some of the homes, right, in the way that we were hoping. But what we have developed is a team that for the last 6 months have been working together. And I just wanted to give you a flavor and maybe highlight some of the things that Dr. Silver mentioned around how working together in a team using a quality improvement lens has allowed us to learn. So remember I mentioned in that Pareto diagram, we had this issue where we identified in the summer that, in fact, we could provide as many general medicine consults as we want, and we're not going to be able to address these transfers where people hurt themselves, fall, injure themselves, and need to come over and end up just getting an X-ray. And so we were trying to think, like, what team would we need to assemble to design an intervention to allow for the safe management of long-term care residents in their home setting if they've injured themselves. And so just to give you a flavor of how complicated or complex this is the process map. So one of the things we thought was, well, if you need to construct a process map to try to figure out all the different steps, who needs to be involved? So one of the biggest mistakes that I've made in the past is trying to build a process map without bringing in a diverse set of perspectives on the issue. So let's think this through. So there has to be an injury assessment, for example, right? So I purposely made this process map small just to kind of emphasize the complexity, but I'll just break down the key steps. So there's a whole series of steps around injury assessment that we needed to sort out. And in order to do that, we had to work with the long-term care nurses, because they're really the ones at the bedside who have to often make the determination around how serious the injury is. Often the primary care providers are not on site, and they work collaboratively with their nurses to try to figure out whether or not a situation warrants a transfer. We also had an emergency room doctor involved because, and just to be clear, all of these individuals have dual clinical expertise and quality improvement expertise. So that's something I'm going to talk about in a second. But we really wanted to figure out how can we help the nurses perform a simple assessment at the bedside to convey the information effectively to the primary care provider so that everyone felt comfortable in the accuracy of the assessment around whether or not the type of injury is the type that requires a transfer. we needed to figure out, well, what are the criteria for transferring someone to the hospital? And so there we needed to bring together the primary care providers, the orthopedic surgeons who really have the deep knowledge around what types of fractures can and can't be managed safely in the long-term care setting. But we needed to also speak to residents and caregivers around what is an acceptable time frame to wait in the long-term care setting with an injury to allow for the investigations and assessments to be done to determine what the treatment plan should be. So here you can see there's a different team that we had to assemble. Then we had to figure out how are we going to get someone out to the home to take an x-ray. And so it turns out, and I didn't know this until I started in March of 2020, that there's this company which actually has been in place for over 20 years. And their entire business is mobile diagnostics. And so they actually drive around in these trucks and vans with portable x-ray machines into long-term care homes and retirement homes. And the amazing thing is that they've been in place for years. And so they already had relationships with different homes. And so in the home where we were piloting, which was Baycrest, STL imaging already goes 5 days a week and is available to do x-rays. And so what we needed to do was figure out a rapid access protocol so that if someone were to fall and injure themselves, there was some way of signaling to the diagnostic imaging tech and company that this is an urgent x-ray that needs to be read and uploaded urgently onto the system so that it could be reviewed by the orthopedic surgeon. And so you can imagine this required a collaboration between nurses, primary care providers, the orthopedic surgeon, the diagnostic imaging provider, but also IT, because we needed to figure out, okay, well, how are we going to modify the order set for imaging, for example, so that they could indicate that this is an urgent LTC plus request. And then, of course, you can't leave someone with an injury without managing their immediate symptoms. And so we had to figure out, okay, while we're trying to sort out if there's an actual fracture or not, can we properly immobilize people in the home with equipment? And so we had an orthopedic surgeon, a rehab physician, long-term care provider, nursing, physiotherapy, and of course the finance office, which I didn't think about because, again, who's going to pay for the boots? Who's going to pay for the slings? They're not usually available on site, right? And in fact, we needed to sort all that out. So that's another team. And then, of course, we had to figure out how are we going to create a new pathway within the fracture clinic. And so we needed the orthopedic surgeon, the clinic administrative assistant, clinic manager, primary care provider, and again, the IT specialist to figure out, okay, how are we going to get these images uploaded and easily viewed, okay? So you can see here that we actually had to assemble a multi-institutional, cross-sectoral, interprofessional team. So I know that, you know, when Ivan sort of spoke about the importance of multidisciplinary or interprofessional, what I would sort of highlight is actually for many of the things that we do, our patients don't live in one sector. They live in a community sector, they live in an ambulatory sector, they're in rehab, long-term care, acute care. And so what I've learned through this process is that, in fact, the team really does need to have a multi-institutional, cross-sectoral kind of element to it if we really want to provide the integrated care models that our patients often need. So if I think about your patients in mental health, I would think, okay, well, what are the sectors that we need to be thinking about? What are the institutions? Who are the professions that need to be involved? And in fact, these individual team members, I think, bring different types of knowledge to the table. And this is where I think there was really deep learning amongst the team members. So people brought to the table subject matter knowledge. So the orthopedic surgeon brought their knowledge around how to manage fractures, and primary care providers brought their knowledge around how to manage injuries in the long-term care home. And physiotherapists brought their knowledge around how do we apply a splint if you don't have a lot of expertise in that area. That's subject matter knowledge, knowledge that's from your own clinical professional background. Some people bring organizational knowledge to the table. How do things work at Baycrest? How do things work at Sunnybrook? How do all the different departments connect to one another? Who are the key players? That's organizational knowledge. Then there's improvement knowledge. Many of the people were both orthopedic surgeon and quality improvement expert, emerge doc and quality improvement expert. We had 3 people on our team who had quality improvement masters, 5 or 6 that had quality improvement certificate background. And in fact, we actually embedded learners into this project. So there was an individual who was a general internal medicine resident taking our certificate course, and his project was derailed by the pandemic. And so we actually brought him in, and he helped to develop some of the materials to help educate the nurses. And then the last type of knowledge is a knowledge around how to collaborate effectively. So I actually think these are the 4 knowledge domains that are really, really important if we want to optimize team-based CPPD. And in fact, CPD, continuing professional development, had a really important role in the actual intervention itself. And what I will say is that Zoom actually broke down a lot of the barriers that I think, and it's not just Zoom, Microsoft Teams, whatever, but the point is that the fact that we had to work virtually together actually allowed us to bring people together from long-term care, acute care, and the community in the same environment to have conversations on a regular basis. Something that I would say prior to the pandemic was difficult to do, and I'm hoping will be something that will keep with us as we go forward. But here's some examples of how we used and actually leveraged CPD as an intervention within our quality improvement initiative. So that resident that I told you about, he had an interest in medical education as well. So he worked directly with the primary care provider, the orthopedic surgeon, and the nurse manager to create some cases and scenarios for the nurses to work through to start to learn how to assess residents more independently when they've had an injury. This was a new skill set for nurses, and collaboratively together, they were able to create some CPD for nursing around how to perform these assessments. And in fact, we had someone who had a real interest in the use of technology for learning, and she's actually created a whiteboard video because we heard from the nurses that, you know, they're often on shift, they can't often attend these sessions in person, but they'd be more than happy to spend 3 minutes and watch a video if it could really get to the key points. And again, we have some very early pilot data. So we just piloted it for the last month, and there have been 5 instances where we've activated the pathway. None of them required a transfer to the emergency department for their initial imaging, and 2 out of the 5 did not even need a transfer to the fracture clinic. So whereas most situations there would have been 10 transfers to acute care, we were able to avoid 7 of them, which I think is a pretty big deal for a pilot, and we're now launching it at Baycrest, and there's also a pilot up and running between Providence and Unity Health. And so this is the team and all the organizations involved in this work, and it's something that I've never really encountered before, is this sort of, like I said, multi-institutional, cross-sectoral, interprofessional team that we've assembled to put this work together. Okay, so I'm just looking at the time. I'm wondering if it's okay that I just very quickly in the last 5 minutes talk about organizational alignment, and then we can open things up for questions. Is that okay?
Yeah.
Yes.
Okay, perfect. I will just say that I have often talked about the importance of aligning your quality improvement work with your organization's strategic goals. But what I failed to recognize was that that's not enough. So I used to always say, well, if your organization's interested in choosing wisely, then if you do a choosing wisely project, then your organization will align, and then somehow magically resources and integration will flow. But in fact, actually, there are deeper levels of alignment that I've learned to be important through this experience. So I would say that you need alignment of strategy, alignment of teams, and alignment of work. And what do I mean by that? What I mean is that there's an alignment of strategy that our program has with our key partner organizations. So for example, Women's College has a whole virtual care strategy. So of course, anything that we're doing that's virtual care oriented is going to be of interest to women's. Sunnybrook has a strategy around an integrated community. So anything we do around integrating acute care, long-term care is going to fit within their strategy. But remember, just aligning to those strategic priorities is not enough. You need to align the teams as well. So we had alignment of our teams with long-term care. We had alignment of our teams across institutions and sectors. We tried to align our teams of academic QI faculty and hospital operations team members. We aligned project managers work with hospital QI specialists, CPD educators with quality improvers, and of course, aligning our work with community-based service providers. What do I mean by alignment of work? So this is it's an example actually of how we really didn't understand the internal processes at Sunnybrook. So what happened was we launched the initiative, we put in place a requisition form. And this provider sent 2 different referrals for the same patient for the same problem. The one on the right was our referral that we put in place for this new pathway. The one on the left actually was an existing pathway through a program called SCOPE. And for those, I'm sure many of you know SCOPE because there's a very strong mental health component to SCOPE. But SCOPE at Sunnybrook allows primary care providers to actually make a referral directly to fracture clinic. And so this physician was already registered with SCOPE, but also working in long-term care, wasn't sure what to do, and so sent both referrals in. And so the SCOPE nurse at the fracture clinic also happens to be triaging referrals from other hospitals. And so she received these 2 referrals and emailed my colleague saying, you know, what gives? What's all this about? And she was not aware that we had done this because we didn't think that this would land on her desk. But what we realized was that we had a conversation with her and the nurse manager at the fracture clinic. And it turns out that in fact, they were very, very keen to work with us to figure out a streamlined process for our intervention to be harmonized with the existing process for SCOPE. And so when I talk about the alignment of strategy and the alignment of teams, at the microsystem level, there needs to be alignment of the work. The reality is that if what we're doing on our initiative doesn't align with the work that's already happening in the place where you're trying to do make the change, it's just really, really hard to integrate. And so the amazing thing is that because we integrated with this existing resource, we didn't need to hire someone, an administrative assistant, to actually manage all these referrals because the SCOPE nurse was very interested and keen to do this and actually offered to do all the triage and administration for this. And not only that, was willing to start collecting some data for us as well. And why was that? Because I think there was an alignment of work, through an alignment of teams, through alignment of strategy, okay? So to summarize, CPPD, in order to sort of achieve its greatest impact, I believe it has to be data-driven, team-based, and organizationally aligned. What about my personal CPPD outcome from this work? So I actually learned a ton about how to provide care and long-term care. It was like eye-opening for me, despite the fact that I admit a lot of people from long-term care. I gained these new skills around project management from working with project managers that I never was aware of. And I really, I think, developed a new set of team collaboration and leadership skills that I really didn't have prior to this experience. And I think the work that we're doing is leading to some practice development as well. We've created some new partnerships. I think we now have this living lab where we can insert learners at different stages to participate in the work and learn about quality improvement and team-based care, kind of like what Ivan said, right? The clinic is the lab, is the learning. And in this case, this new program is the learning. And I'm hoping over time, we're gonna be able to impact the care for long-term care residents. So maybe I'll just close by asking you to reflect on, after this talk, what data sources are available that shine a light on the urgent health system problems in mental health? What teams need to be engaged in interprofessional CPPD to tackle these problems? And how do you align strategy teams and work to achieve optimal patient outcomes in mental health? The last thing I'll just say is, if you're interested, this is a shameless plug. We do have, as Karen mentioned, a new improvement fellowship that we have open for applications until next Friday. And we also have a symposium where we have Dr. Leora Horowitz coming from NYU to talk about learning health systems. And we'll be launching our new strategic plan for the next 5 years for the center. And with that, I'll close. I have my email there. If you have any questions you'd like to send me, I'd be happy to answer them that way, and leave a few more minutes now for the chat.
Thanks, Brian, for that very intriguing talk. And as I mentioned again, it's very relevant in light of everything that's going on. And it sort of fits in to the whole theme of the day of working together in teams, and the aspect of organizational alignment. And obviously data, I mean, that is one of the reasons why we're here. But I want to first go over the question from the audience, and then we'll come to one of my questions. So there was a question, was Brian, a practical question. When you assemble teams, you showed each step, who should be involved. When you organize these teams, do you meet with teams individually or work through the mapping related to teams, or do the teams work together towards to map?
Yeah, so it's I would say that actually the mapping exercise is it's a bit of there's a feedback loop to it. So what you really want to do is you want to assemble a team. It's often interprofessional, but what you want to do is identify who are all the individuals that are affected by the process or who influence the process, right? And that's the first step. And then what will often happen is that I think that you will often tend to assemble teams in different ways depending on which aspect of the process you want to sort of understand more around. Like, you don't really need the orthopedic surgeon to be involved in a discussion around how we're going to create an order set within the long-term care EMR, right? Like that. So I do think there is a certain amount of like pulling people in when needed. The other thing I would just say is that process mapping is not a static activity. We continuously update that process map based on new information that we identify. And again, depending on what we learn, we might bring new people in.
Okay. There's a nice link to David Gretzer mentions, nice link to the QI.
Thank you, David.
Wonderful. So the other question that I had was, you know, you mentioned the alignment piece. I mean, in a lot of hospitals, the quality improvement area is sort of, you know, there's two different branches. You know, there seems to be the physician-led quality improvement aspect, and then the other clinicians, nursing plus other clinicians. And I sometimes wonder, are the two things aligned? You know, it seems to be sometimes that they're working independently, even though they're trying. I mean, what are your tips on ideas on how these things could get, you know, strategically, organizationally aligned, so maybe the end product is more efficient in terms of patient outcomes? And you know.
I would say my biggest misstep up till this point in my career has been to align and reach out late in the process, you know, and I think that, you know, co-production, co-creation occurs from the ground up, and I never really appreciated that until this initiative, probably as much as I should. I would say that there are some really, really talented and experienced quality improvement experts within our hospitals. Many of them have very different skill sets. So I heard earlier someone say, well, how do you work effectively with people that don't have a strong clinical background? I will tell you that they feel, they're asking, how do we figure out how to work with these physicians and clinicians who don't understand the first thing about project management, you know? And so I would say that actually again, it's like, how do you harness the different knowledge bases that different team members bring, and celebrate the fact that we do bring different knowledges to the table, and how do you work together? So that would be the first thing I would say. The second, again, is that I think that as long as the strategy and teams and work are aligned, then I do think then that those silos tend to go away a little bit. You know, early days in this initiative, the director of quality and safety had heard that we were working on this, and she had a couple of team members that didn't have very much to do because some things had been put on hold. And she actually reached out and said, I'd love to have a couple of my project managers, QI specialists, work with you. And it was amazing because these individuals have definitely pushed our initiatives forward in ways that we never could have done, because they just they're organized. They make sure that we follow through on things we decide to do. They have deep institutional operational knowledge that we don't have. So I think it's about celebrating the perspectives and the knowledge that other team members bring. And I think if you really do that in an earnest way, then I think that's probably the first step towards bridging that gap.
Thank you, Brian. But it's a very intriguing conversation, and thank you for bringing some of. I know some of these data and information is very early on, and you're working on it. But I really appreciate it. I think it enlightens us to some of the background stuff that's going on, and all the work that you're doing. Again, to make the time to speak at our conference, we really appreciate it. I know there's so much going on personally today as well, but I appreciate that. Hopefully everything's okay on that end as well. And obviously they have your contact email and stuff, and people can reach out to you. And good luck with everything and all you're doing as the Director of Patient Safety and Quality Improvement. Thank you.
Thank you so much for including me today. I really appreciate it, and congratulations on what was a very, very stimulating meeting.
Thank you, Brian.